Okay, I think everything is working here. Good afternoon, America. Hi, CNY Nation. I'm Dr. Randy Fink, live from the beautiful CNY Fertility in Colorado Springs, Colorado. We are live coast to coast by internet and internationally as well. I am the clinical director of IVF services here at CNY Fertility Colorado and the medical director at the Miami Center of Excellence in CNY Fertility in Miami, Florida. A wonderful place to do your monitoring. It looks like everyone is just stepping on. So thank you very much. Nice to see everybody. It looks like, Felicia is going to be here next week. We're happy to have you. We're looking forward to seeing you. It's been a cold week here, I think, in Colorado Springs. Had a little bit of snow, but I understand our friends on the East Coast are really getting hammered up in the Northeast with that big storm. And of course, our thoughts go out to all those on the West Coast. Straight up here, 4 o'clock in the mountain time, which means 6 o'clock on the East Coast and 3 o'clock on the West. Gosh, they're getting a lot of rain and snow and floods and everything else. And so I hope we can all join together to send our warmest thoughts to our friends in California at this point. Oh, you can't hear me. That's interesting. Now, why is that? Somebody says they can't hear me. It looks like this side can't hear me. I think this side can, and it looks like this side can. So I'm wondering what's going on here. Maybe if I pull this thing out. Let's see. Is there audio here now to the folks on the Instagram side from CNY? How about that? Hello. Well, so here's what we got. We've got Facebook and YouTube over here. We've got a couple of different CNY feeds. Can you? Oh, it is working now. Okay, so we had a little microphone issue there, but I was just saying, hey, it's glad to see everybody. So thanks for everybody being here. The mic on the CNY Instagram right here was connected here. And so hopefully you can hear me well enough without this little extra wireless mic that's connected up to that one there. But sure, I'm glad to have everybody with us today. It's kind of been a tough week over here. I do want to send a special shout out to, first I'll say a special shout out to my mom and dad in Mobile, Alabama, and hopefully everybody will join me in sending thoughts to my dad, who is in the hospital right now, and hopes for a speedy recovery there. Hi to Lauren and William in Miami. Hi to Amber in Kentucky, and a very special hi to Brandis, who just joined driving home from the office here. I say it's been a tough week because we've had some, kind of strange things happening over here, some very unintended results. Sometimes, thank you, Felicia, I appreciate that. Sometimes people not getting pregnant when we think they should, and sometimes people getting pregnant when we didn't think that they would. It brings up kind of the roller coaster ride that is fertility treatment and IVF. And I think probably all of you can relate to what I mean by that some roller coasters you get on, and it's a perfectly fun ride. You kind of go back and forth, you feel the breeze in your hair, and it's a nice experience. This particular, I think the roller coaster ride of IVF is one that isn't necessarily so fun. And sometimes, you jerk to the left and it gives you a concussion, and then it turns you upside down and you get nauseated and want to vomit. And hopefully what it means is that we all end up going into the station at the end of that roller coaster ride and getting off that train one more than we got on with, and that is the one that's in your tummy there. So that's certainly our hope, but that roller coaster ride is is not always so fun. And I just want you all to know that we feel it too. We go through the many of the same ups and downs that you do while going through treatment, while waiting for that beta, waiting to get that result from the transfer, waiting to see how many eggs you retrieve, waiting to see what's going to survive. And as Melissa says here, it's always a numbers game. You got to keep playing to win, and that's a very excellent point, Melissa from Instagram. Thank you for sharing that. So that said, let's see if we can't start with some questions. Anybody with questions, feel free to throw them out here. Nice to see Autumn. Nice to see Amber. Nice to see, well, hopefully somebody just said here that my voice is a little bit low, but hopefully you can hear me there, since this microphone ended up not working so well. It looks like Chiquita on the Facebook side is saying, my tubes are blocked. What can I do? And the easy answer to that, my friend, is in vitro fertilization. So regular fertility, regular conception happens when the ovary releases an egg, sperm swims inside through the vagina, through the cervix, into the uterine cavity, and then up into the fallopian tubes, where the egg has been taken up after it's released from the ovary. Sperm meets egg in the ovary, and that is where fertilization takes place. Once the fertilization happens, that egg and that embryo rather moves its way down into the uterine cavity, where it implants. And once it implants, God willing, it stays there, and that's what your pregnancy is. When the fallopian tubes are blocked, and that's what we call tubal factor infertility. One of the more common reasons that people can have difficulty getting pregnant, that means there's a block in the road so that sperm simply can't meet up with egg. And when that happens, what do we do? Well, we can do fertility that does not involve the fallopian tubes, and that's what IVF is. And of course, the process of IVF is where we give you some medication to rev up the ovaries in order to get as many eggs as we can get, which we then retrieve from the ovaries under a little bit of sedation done in one of our offices. It's a vaginal ultrasound guided procedure. Eggs come from you. They go to the laboratory. We have partner sperm or donor sperm, depending on what we're using. One sperm goes into each egg, and that creates embryos. So rather than that embryo being created in the fallopian tube and working its way down into the uterine cavity, now what's happening is that we're making that embryo in the lab, and that's what in vitro fertilization really means. We make that embryo, and then we transfer that embryo back inside of you in order, in hopes that it's going to stick, and when it does, voila, you're pregnant. So Chiquita, that's the way around fertility when your tubes are blocked. Getting all kinds of good questions over here. And let's see what we've got. Tested versus untested embryos. And that comes from M. Some Dancer. Howdy, nice to see you. Glad you're with us today. Tested versus untested embryos. So I think the testing of embryos, which is what we call PGTA, and that's pre-implantation genetic testing of aneuploidy, for aneuploidy. PGT testing is a great tool to take a large number of embryos and to be able to narrow them down to find the group that is more likely to get you pregnant. Now, there are some practices in the United States that mandate, that require you to do PGT testing on your embryos in order for them to transfer the embryos to you. Why do they do that? They do that for the same reason that many folks end up coming to CNY instead of staying with them, because so many practices are concerned with the numbers. And in fact, I will submit to you that if you look on the internet and you look at success rates with IVF, what you will see is that there are some practices that report these astronomically high success rates with IVF. astronomically high. And that's probably because they are cherry picking or selecting the people for whom they will offer that service. So if you're 25 years old with a blocked tube, with blocked tubes, you're very highly likely to make good embryos, and you're going to probably be successful with IVF. If you have tested embryos, that gives us our highest probability of success with IVF, and that's a 60% probability. Um, if they are selecting out those people who are more likely to have better outcomes, and that means younger, healthier people, people with a limited body mass index, so heavier people are excluded, people with diminished ovarian reserve, and that is the AMH blood test that typically, if it's less than 1, many practices will turn you away from IVF. We don't do that. And so that's why when you see the success rates that are reported for IVF, what you're really looking at is a bunch of gibberish, because truthfully, we all really have about the same kind of success. And that is that roughly about 45 or so percent of our frozen embryos that are transferred across the board are generally going to result in an ongoing pregnancy. Now, we say with a tested embryo, that's a 60% number. With an untested blastocyst, that's going to be about 30%. I saw there was a question over here from the CNY Instagram, and what about the low-level mosaics? The mosaic embryo is one that's sort of in the middle. Mosaic is a result that comes back from the PGT testing that tells us that the portion of the embryo they tested has multiple, or at least 2 kind of different cell lines in it, one of which is normal and one of which is abnormal. Now, does that mean that you're going to have an abnormal baby? The answer to that is no. I said that the euploid, or the normal, the tested normal embryo, has about a 60% chance of success. The untested blastocyst has a 30% chance of success. What we say about the low level or even the high level mosaic is that it gives you about a 40% chance of an ongoing pregnancy, with nearly as high, almost 100%, the likelihood that it is as normal an embryo as is the euploid embryo. So what does that mean? Does that mean that you should be throwing away your or discounting your mosaic embryos if you've had them tested? The answer is no, absolutely not, because they have a lower probability of implanting, still more so than an untested blastocyst, but every bit as likely to be a normal baby as your euploid embryo. So that's my thoughts. I think that testing is useful for narrowing down the cohort of embryos that's more likely to get you pregnant. Now, sometimes we'll see that there's 2 common misconceptions there, and this is probably a good time to talk about those. I see folks really here every day who say, well, I'm 40 years old, so I have to do PGT testing because I don't want to have an abnormal baby. And I would submit to you, let me find one patient who wants to have an abnormal baby. No one wants to have an abnormal baby, but that's really not what PGT is for, because the abnormal embryos typically don't implant. You usually never see a positive pregnancy test from those abnormal embryos. Now, sometimes those embryos can implant and can result in miscarriage, which is a terrible tragedy to have to undergo. But the odds of having a baby with a chromosomal abnormality in a live birth is very, very low with IVF for that reason. So, doing PGT testing because you want to have a normal baby, not the reason to do it. Doing it because you think that you are old and have to do it, not the reason to do it. So if you have 1 or 2 embryos, I would suggest don't risk testing it, because you may not get an embryo that grows to blast. Whereas if we put that embryo back inside of you, let's say at day 3, our bodies as humans, we have repair mechanisms. You have the magic sauce in your uterus that may let that embryo grow, whereas it might not have grown in the lab. So if you're limited in the number of embryos, you don't need the lab to tell you whether an embryo is normal or not. If you put it back in you, it's either going to stick because it's normal or it's not because it isn't. And you just saved yourself a lot of money on the PGT testing. So that's kind of my feeling on that. Does taking a medication like norethindrone, this comes from, looks like Swife Queen, or I'm not quite sure how to say it, but you know who I'm talking about over here. Does taking a medication like norethindrone for endometriosis decrease egg reserve? The answer to that is no. Norethindrone is a synthetic progestogen. It acts in the body like progesterone, and it has the ability to, in and of itself, to have some suppressive effect on endometriosis. It's a very good question. Endometriosis itself may have some effect on diminishing egg reserve, or at least accelerating the decrease in egg reserve that's associated with aging. Norethindrone is often used as an add-back therapy to other types of therapies that we use for endometriosis. So, for example, the classic treatment for endometriosis has always been Lupron. Lupron is a shot that you get either once a month or once every 3 months that turns off the hormones. And while the hormones are off, that allows the endometriosis to, if you think about it, to sort of dry up and blow away. We're taking away the food supply, as it were, to that endometriosis. Well, you can imagine that if we turn off your hormones, how do you think you're going to feel? Not so good, right? Because basically what Lupron's doing is putting you into a temporary menopause. Menopause is that time when you are without hormones because you've used up all the eggs in the ovaries. Well, if we used up the eggs and we have no hormones, you start to get the hormone-related, the absence of hormone-related side effects, the things like hot flashes, vaginal dryness, sleep disturbance, there's some leg cramps. Giving add-back with norethindrone ultimately lessens some of the side effects associated with hormone withdrawal therapies like Lupron. So it's not that the norethindrone decreases egg reserve, it's that the endometriosis itself might. Looks like, well, I can't pronounce the name there, but SW33T Ashon 3Y. Wow, that is a mouthful, man. I'm doing a reciprocal IVF with my wife, and I will carry the baby. So that is great. Congratulations, you guys. For those who may not know what reciprocal IVF is, in a same-sex female couple, one member of the couple can provide the eggs that we will fertilize, typically with donor sperm, to create embryos that then go back into the other member of that couple. And I think it is one of the coolest things that we do, you guys. So I'm so proud of you for being able to do that. So reciprocal IVF. So your wife's eggs and you are carrying. Will the baby have both DNA, since the blood from me is going through the baby? Well, you know, that's a really interesting question, and there is some debate on that. But the kind of classic answer to that is technically no, that the baby will have the genetic material that comes from the egg donor and from the sperm donor. However, you are 100% right that every drop of blood that flows through your baby will be your blood. So there is no question that that is your baby. And this also brings up something that we've talked about before that's called epigenetics. Epigenetics tells us that there are a series of switches that can either be on or off. And there's call it 1 million switches that can be on or off in any particular combination of orders that is imaginable. And whether those switches are on or off depend upon the environment in which that embryo grows. Those switches will control things like, is this baby going to be artistic or is this baby going to be mechanical? If this child is artistic, is he or she a singer or a poet? Is this baby going to be a piano player or a flute player? And of course, all the artistic things come to my mind just from my own background. But all the different things that make up your child's behavior are generally related to the environment, or are believed to be related to the environment in which that embryo grows, i.e., your uterus. So that's what epigenetics is. The eye color, the hair color, and certain other features of the DNA will be controlled by that DNA. But so many other things are controlled by whether those switches are on or off. And that is epigenetics based upon the environment, your uterine environment there. Congratulations to you guys for doing reciprocal. I think that's really just fantastic. 24 years old, looks like TS Wiz 67, 24 years old with a low AMH. What are my odds with IVF? So again, the AMH, or the anti-Mullerian hormone, is a qualitative measure of what we'll call your ovarian reserve. It does not tell us whether or not you will get pregnant. It does not tell us whether or not you can get pregnant spontaneously. Really, what it suggests to us is how your ovaries are going to respond to our medication to stimulate them. So the question is, if my AMH is 1.3, which is low for the age of 24, what does that tell me? Specifically, that tells me that, okay, you may get fewer eggs than someone at 24 years old who has a normal, quote unquote, normal AMH, which might be a 4 perhaps at that point. So you may get fewer eggs. However, at 24 years old, the DNA that's in your eggs is exquisitely stable. So you have a very high probability of producing normal eggs that will make normal embryos. So I would tell you that your odds with IVF are very, very high because you're embarking on this process at 24 years old. So there are folks who are, let's even say 40 years old, who have AMHs that are even high for their age. So what does that mean? It means that we may be able to get more eggs than we might expect for someone else at 40 who has an age predicted AMH, but we're still up against the DNA thing. And that is that DNA becomes less stable as we mature. So at 24, your odds are great. So here's one from baby Joe. I had cancer and went through chemo and was told I have a low AMH. There's no way possible for me to have any eggs. It's really, really slim to none. And I would say, well, so there are a lot of folks who are going to go through cancer treatment, chemotherapy, who will opt to freeze their eggs before they begin the process. And there are actually a number of grants and things out there that make that really accessible to everyone, that will pay for the medications, that will pay for the treatments. So if there's anyone you know who is in that situation, please encourage them to reach out to us. We will get such a person a priority appointment with us and get them started ASAP. Really try to expedite the process so that they can retrieve eggs. I would never say never there, baby Joe, because it really depends on the number, and it really depends on what happens. There are some chemotherapy agents that will, for lack of a better term, they will fry the ovaries. And they will use up or kill off the remaining eggs and really kind of make someone menopausal at an early age. But fortunately now, with more modern chemotherapy agents, that is less common. It can have some effect on the DNA in the eggs. I would say it really kind of depends on what your numbers are. And I would encourage encourage you to take a real close look at that, because every day we see folks who are in that kind of scenario, who have been told it's impossible for them to have a baby, but yet they leave from us with a baby in their arms. So hopefully we can be of some help there, baby Joe. On the Facebook side here, it looks like Linnae Bowerbird says, what do you suggest for priming for a woman 38 years old with several autoimmune issues? You ask two really good questions there. And so let's focus on those things. First is autoimmune. What is autoimmune? That's when your own immune system is attacking some portion of your body for some reason. Well, certainly suboptimal. We do believe that inflammation and the immune system has some effect on just about everyone who's trying to get pregnant. So that's why we invoke an immune protocol really for every fertility treatment that we offer. So during treatments, Linnae, we will provide one of our immune protocols for you depending on what those immune issues are. So you also ask about priming. Priming is when we give you some medication before the stimulation portion of the cycle with a goal of trying to improve your egg quality. So how would I prime you? My typical priming agents are Omnitrope. Omnitrope is human growth hormone. And if you have used HGH or Omnitrope, or if you haven't and you've heard of it, there's very little harm to doing it, especially for folks for whom we have concerns about egg quality. And there is a coupon. There's a little survey you can fill out online, or we can send you the link for a coupon that will get you that Omnitrope for free. So given that it's a very expensive drug and you can get it for free, when it is indicated, there is really no harm to do it, especially because it can cost you zero. So I would use Omnitrope. I would use low-dose naltrexone. Low-dose naltrexone has been used in the anti-aging community for a very long time. What it does is that it stimulates your body's production of endorphins. So endorphins have a positive effect on fertility and egg quality and have a very strong anti-inflammatory property to them. So many of the folks in the non-pregnancy world who are using low-dose naltrexone for anti-aging purposes find that many of the aches and pains that they get, people with chronic pain, that pain often goes away or is certainly lessened. Lots of those folks will never tell me they'll never get a common cold again because of the effect on the immune system. I've used low-dose naltrexone to treat chronic pain associated with endometriosis. Low-dose naltrexone is a very good thing in autoimmune disease. So there's one way to go. We also think about depending on how far in advance, we often will use Plaquenil, which is an immune modulator. We will often use some estrogen and progesterone, not specifically as it pertains to the immune system, but that's the language that the ovaries speak. And so it helps to get some of these other medicines going to the ovaries, where the anti-inflammatory effect can be really quite profound. So Lenny, hopefully that helps. I think really the answer has to do with kind of what specifically the autoimmune issue is there for you. And Morgan is asking, hi Morgan, are there any risks to doing an egg retrieval that could possibly cause permanent damage that would prevent conception or pregnancy in the future? I would have to say, not really. You could also ask me the question, are there any risks to driving in your car that can cause permanent damage that can prevent you from getting pregnant? And the answer is, well, yeah, of course you can get in an accident and have something terrible happen to you that can keep you from being able to get pregnant later on, or it can kill you. The odds of something happening in your car driving to get here are infinitely higher then the odds are of something bad happening to you with IVF. IVF has now been around for decades. It's a very safe procedure. We have a tremendous amount of experience with it, but the standard risks to retrieving an egg, we're doing that with a needle, right? So whenever we use a needle, what happens if I poke you in the skin with a needle? Risk for infection, risk for bleeding on the inside, and theoretically a risk of infection, right? Because that needle is going through the vagina. And of course, the vagina, even though we prep the vagina to decrease the bacterial colony count before performing any kind of procedure that involves the vagina, the needle is passing through the vaginal wall to get to the ovaries. So there's always a risk of infection associated with that as well. So I would say theoretically, there's risks to everything that we do, but fortunately, IVF, particularly in egg retrieval, is very, very safe. So let's see what else we have here. Daisy Dum Dum. Oh, I like that name too. Hi, Daisy Dum Dum. If someone has a low AMH, do you all immediately recommend donor eggs? And does PRP increase the AMH? Well, so again, the AMH is a measurement of the ovarian reserve. Do we automatically recommend donor egg? And the answer is no. There are, as we talked about, what many other practices will do is they will say, oh, if your AMH is low, we're not going to do IVF. If you want to do anything, you have to do donor egg. Otherwise, we're not going to help you. Well, my personal feeling is that I'm not God. I can't tell you exactly what's going to happen. I can discuss with you the probabilities or the likelihood of being successful. But even if that likelihood is low, that doesn't mean that the success story might not come from you. So in that scenario, you might decide, well, you know what? I would like to try IVF because I need to convince myself that I've tried, that I've done everything I can with my own eggs. One of the options that you can exercise is the ability to do IVF on yourself with a donor egg backup. And what that means is that you go through the IVF process, we retrieve whatever eggs we can get from you. And while we're going to fertilize your eggs, we also fertilize the donor eggs that you've purchased. So what results from that is that one way or the other, we have an embryo that we will be able to transfer back to you that has a good probability of being able to get you pregnant. So I would never say we immediately recommend donor eggs. We may discuss somebody who has a very low AMH that donor eggs are going to give you a higher probability of being able to get pregnant, but that doesn't mean that you're ready to jump into that process yet. And we understand that. Daisy Dum Dum, you're not such a dum dum. I don't know that I like the name there. What thoughts on a day 3 versus a day 5 frozen for advanced age? And this comes from DWright1 over here on the Instagram side. Hi, nice to see you. By the way, if you just joined, we're about halfway through Fertility with Fink and Friends live from Colorado Springs, and I am Fink and you are friends. So glad to have you here. When we freeze an embryo or when we transfer an embryo typically depends on how many embryos that you have. So we like to think that if we have 5 or more embryos, we encourage you to grow them to the blastocyst stage, because when we're doing that, we're allowing nature really to help us to select the embryos that have a higher probability of being able to get us pregnant. If we're more limited in the number of embryos, let's say we have 3 embryos or 4 embryos, we recommend that you freeze or transfer on day 3. So folks who are of advanced age, and we can define that however you like, but certainly someone who's a little older, may be less likely to produce a large number of eggs that will result in a large number of embryos. So in that scenario, we might suggest that you do a day 3, because all day long, every day of the week, I would much rather see an embryo go inside of you than an embryo dying in the lab. You have and you are the magic sauce. Your uterus is better than any lab we have and may be able to make an embryo grow, whereas it might not have grown in the laboratory. So at the end of the day, if we're limited, put an embryo back inside of you. There's no reason to wait until day 5. Yes, it's true. A blastocyst or a day 5, day 6, or day 7 embryo has a higher probability of being able to get you pregnant, but that does not mean that a day 3 embryo can't get you pregnant. Of course it can. So again, much better to have it in you than not. I, Andre 28, hi, nice to see you. Ask, can we speak? Can I speak to if an HCG or Neupogen wash is best for a frozen embryo transfer? So, oh gosh, Dr. Kiltz joined my talk here. I don't even know what time that happened. Wait, we've been talking about keto the whole time. I swear, carnivore. We have been talking about nothing but carnivore. I promise. Go back, watch the tape. You'll see nothing but carnivore. Help me out here, you guys. Come on. Nice. Yeah, I understand Dr. Kiltz is in Vail, Colorado, and he is skiing or some such thing, or snowboarding or something. So I would, I don't know about you, but I'd like to see a video. I'm just saying. Glad to have you, Dr. Kiltz. HCG versus a Neupogen wash for a frozen embryo transfer. So an HCG wash, I think, is something that really everyone should do before a frozen embryo transfer. HCG is, of course, the pregnancy hormone. And when we take a little bit of it and we apply it to the lining of the uterus, what it does is that it revs up some of the proteins. It revs up the lining's ability to implant an embryo. So it just turns on some of the implantation chemistry. And that is always going to be a good thing. It's a relatively painless thing to undergo. Sometimes it causes a little bit of cramping afterwards, but a little straw goes in the cervix. We place a teaspoon or so of that HCG fluid on the inside. I think of Neupogen Neupogen is an immune modulator. And so I think that is a better choice for folks who have had recurrent implantation failure or recurrent pregnancy loss. Also, what goes along there with Neupogen is a PRP wash. PRP is platelet-rich plasma, and that's when we take a tube of your blood and separate out the portion of that blood that has your body's healing components, your tissue factors, your growth factors, and we can place that fluid right back on the lining of your uterus. And I think of it as the most soothing salve that we can make for your body. So PRP wash is another option there. So I hope that answered your question. Can letrozole, this comes from Wendy. Hey, Wendy, can letrozole given during stimulation cause more of an issue than Clomid? In my experience, no. And so let me just explain kind of what Wendy's asking about here. So as you know, during IVF, we use medication to stimulate the ovaries. Typically, that medication comes in the form of an injection, and that's FSH or Follistim or Gonal-F, and some of the LH medication, which comes in the form of either HCG, LH, or a medication called Menopur. Well, we often will add an oral adjunct to that, and that can be either letrozole or clomiphene. Both of these oral medications, and maybe you're familiar with them from having tried them when you've done IUIs, intrauterine insemination or ovulation induction, they just work through a different pathway and help us to recruit follicles, help us to make eggs. The problem with Clomid, with clomiphene, is often I find it has a little higher side effect profile, but it can have a very negative effect on the lining of the uterus. And so here at CNY, we typically go towards letrozole instead of Clomid for that reason. There's a little fewer side effects with letrozole over clomiphene, and there's no effect on the uterine lining. At least in theory, there shouldn't be. So I will often add letrozole for women who are over 35 in some of the data that we crunched. Even right here out of the Colorado office, we found that it can significantly improve the pregnancy rates in women over 35. We use it in those younger than 35 as well in some situations. So I certainly wouldn't be afraid of either of them. I tend to use more clomiphene in certain types of protocols for poor responders or for those with a very low ovarian reserve. There's some different kinds of protocols that we use in those scenarios. So good question, Wendy. Thanks so much for that. Let's see what we've got here. I think I should turn back over towards the Facebook side because I've missed a few here. Ariel is asking, how accurate is the Emma and the Alice test? I'm about to do my third IVF as well as a third egg retrieval. So the Emma and the Alice test is a test that tests what we call the microbiome of the uterus. So the classic wisdom was always that the uterine lining is considered to be a sterile environment. But what we've learned, especially in the fertility world, is that's not always the case. The Emma and the Alice test are designed to show us about what good bacteria are there and what bad bacteria are there. It is an interesting test, to say the least. It shows us a lot of information that we certainly wouldn't have otherwise known. But really, ultimately, what we're talking about here is called chronic endometritis. Chronic endometritis. Endometrium is the lining of the uterus, and an itis is an infection. Well, and so in this case, chronic endometritis is not so much an infection, but a chronic inflammation in the uterine lining. And where this comes from is, it can be from any number of places, and that's what the Emma and the Alice test are designed for us to see. What is the origin of the infection? We have specific ways that we can treat these things. With the Emma and Alice test, it's something that's done usually at a particular time during the cycle, lets us determine precisely what bacteria is not supposed to be there and how much of the bacteria that is supposed to be there is there. Is that a good reason that someone has been unsuccessful with embryo transfers? I think the jury is out on that. I think if we can identify chronic endometritis and treat it, I'm not so sure that identifying the specific organism that's involved necessarily improves the outcome there, but it is certainly an interesting test, and in some cases is definitely worth doing. Felicia, who is going to be here next week, is asking, is there a big difference between Neupogen and Nivastim? No, they're really the same thing. They're different brands of the same medication that's used in our immune profile, immune level 3. And so sometimes insurance will cover one versus the other, or sometimes one, even if you're paying out of pocket, one is less expensive. So that's okay. This is coming from Sandy, and apparently I missed the question before. My apologies. Hi, Sandy. Sandy. I just want to get insight on sperm DNA fragmentation and how to improve our odds. So we've talked about DNA fragmentation before. And so let's just review that. What is a sperm? It's a little piece of DNA with a motor on it. That was my visual, in case you missed it. Let's do it again, coming from the other way. So I swear that was sperm. Just like we've been talking about keto this whole time, carnivore this whole time. That was a sperm, I swear. It's a piece of DNA with a motor on it. Well, as that DNA can degrade and can start to unwind and can start to kind of come apart. So just like it sounds, fragmentation is when that DNA, you start to lose pieces of it and it becomes fragmented. DNA fragmentation can result in poor fertilization of eggs. It can result in an increased risk of embryos not being able to grow due to chromosomal problems, and potentially even later on for miscarriage. Um, the um, the issue with sperm fragmentation, so it can be tested for, we can do a DNA fragmentation test, and we don't do them here. There's only a couple of labs that do. However, the treatment for DNA fragmentation is often the same thing. And the way that I would treat that has to do with the frequency of ejaculation. So you have probably learned that when your male partner is coming to, that's a strange choice of words, when your male partner has arrived with you to provide a fresh sample from the collection room, that they're told not to ejaculate for a few days leading up to that collection. And why is that? Well, certainly with each ejaculation, the sperm count goes down. So we really want the largest count of the freshest, most available sperm we can when it comes time for IVF, because obviously you have invested a lot into that IVF moment. So we want to do everything we can to make sure that sperm is good. If, however, there's an issue of fragmentation, you may already know that there's a problem with that sperm. And so how do you address that? It has to do with frequency of ejaculation before that collection. So typically what the experts will tell a male patient is to ejaculate in the morning the day before, the night the day before, and then in the morning on the day of collection, there for the collection. So that increased frequency of ejaculation, while it will lower the sperm count that's available for the andrologist and the embryologist to be able to select the sperm, it will improve, or it will decrease the amount of fragmentation in that DNA. So hopefully that helps there, Sandy. Odds for with high sperm frag. The odds are pretty good once we recognize that that's what the problem is. So we can decrease sperm fragmentation, and there are some other things that we can do that can help in poor fertilization of eggs in the lab. Calcium ionophore is one of those things that helps with poor fragmentation. That's something that has to be ordered at the beginning of a cycle. It's something that we really have to know there's a good reason to use it. So I wouldn't want you to just call our team and say, I want that because I heard Fink talk about it, because there's a narrow window where that sort of thing is helpful. But odds of dealing with sperm fragmentation are actually pretty good. Light and short periods looks like, oh, actually, I made one thing. My TSH, this comes from MJ Regis. Hi, MJ. My TSH is 0.005. How can I increase my TSH level? Well, I'm not aware of a natural way to do that. So what that tells me is that you are a little bit hyperthyroid, and that has some particular risks. So I would encourage you to seek the counsel of an endocrinologist, because that's usually something that we want to treat. Now, if you are at that number because you are on thyroid medication, what it says is that your medication dose is too high, and that's usually a pretty easy kind of fix. Marilla, I can't quite see the rest of it there. Light and short periods, can I still carry a pregnancy, or should I look into fertility treatments? Light and short periods are not necessarily indicative of a fertility problem. So some people just have heavier periods. There's a whole wide variation in how much and for how long a woman bleeds during her menses. That typically starts to get longer and heavier as we age and after having had kids. But a short and light period does not necessarily mean that there is a problem. It may very well just be part of a normal variation. Now, how would I evaluate that? Well, what I would really want to look at is how thick, Morella, is your lining at the time that you ovulate. That would be the first thing. So right in the mid-cycle, when your ovary is releasing its egg, that's the time that sperm is going to meet that egg, that egg will fertilize and ultimately work its way down to implant inside your uterus. How thick is that lining? Is it thick enough to support a pregnancy? Usually we think of about 7 millimeters. Some people will even say 6 or 6.5 millimeters as being thick enough for implantation. And I would just be curious to see how thick does your lining get at the end of your cycle, just before you get your period, as a predictor. That's how, if I were your gynecologist, I would evaluate that. But odds are no problem. I see a message here from Erica. I see you there, and I will follow up with you on that. Thank you. And let's see what we have here also from the CNY side. Is there a possibility for there to be a clinic opening up in Puerto Rico? You know, I wish we could open a clinic in Puerto Rico. And in fact, I know that Dr. Verdialis in Atlanta has some connections in Puerto Rico. I love Puerto Rico after the hurricane. I lived in Miami at that time, and I raised some money and about 12,000 pounds of relief supplies and flew them there in my airplane over a series of several trips to Puerto Rico for the wonderful and beautiful people of Puerto Rico. I would love to have a clinic in Puerto Rico. Unfortunately, I don't see the probability of a full service clinic opening in Puerto Rico, but maybe a monitoring center. I think that's a great idea. Hopefully Dr. Kiltz is still watching and is going to say, Fink, you need to go to Puerto Rico. Well, you know, I'll do what I have to do. You know, just for the benefit of the wonderful people of Puerto Rico. Good question there. Is there any reason to wait to try to conceive after a pregnancy loss? Well, this comes from Danielle, and that's a really good question there too. Is how long after a pregnancy loss should you wait? Well, we used to tell people after a miscarriage that you want to wait for 3 months before trying to conceive. There really is no evidence to support that. I think that was more just kind of a gestalt thing that empirically kind of made sense. What the data shows us now is that if you have a pregnancy loss and then you conceive again before having your first normal period, that there is an increased risk for subsequent pregnancy loss. Whereas if you've had that first normal period, then there is then the risk for pregnancy loss, recurrent pregnancy loss, is not increased. So I would say wait for that first normal period, and then you should be able to proceed. Now, sometimes I will tell you it absolutely requires a little more time from an emotional standpoint. So your body may heal a lot faster than your heart does. And so you go where your heart tells you, because that is really what's going to make the most sense. Nesh's Best Life says, oh, is there a possibility for a clinic opening in Miami? Well, I'm glad you asked me that question. We have a clinic in Miami. The CNY Fertility at the Miami Center of Excellence is currently a monitoring center, and will hopefully continue to expand. We've got Sarasota, which is a short 3-hour drive from Miami, that's going to be opening as full service in this summer, and we may even have more full service opportunities opening in the Orlando area as well. So we would love to see you in Miami. And I came here to Colorado from Miami, as you can tell from my tan. obviously. It's just obvious. What else is there to say? Oh, let's see what else we have here. We're going to start to wrap it up. So let me see if we can try to throw. Oh gosh, Elisa says, is there any better health class? You learn so much here each week. Well, thank you for that. I appreciate it. The impact of adenomyosis on IVF. And let's talk about what adenomyosis is in our last couple of minutes here, because it is a term you're likely to hear. The uterus is made of muscle. And inside that muscle is a glandular lining. And that glandular lining is what gets thicker and thicker and thicker during the month until ultimately it realizes that you're not pregnant if you're not, and then it sloughs off and your body says, all right, we're going to try again fresh next month. Or that glandular lining becomes the world's best baby blanket and is the place where your embryo implants. Well, sometimes, particularly as we mature and after previous childbirth, the glandular lining can grow into the muscle of the uterus. And that's what's called adenomyosis. It often results in very heavy menses. It results in sometimes very painful menses or in pelvic pain. And adenomyosis can adversely affect IVF and just pregnancy outcomes in general, likely due to the change in blood flow that happens throughout the uterus. So we can treat adenomyosis with the same kinds of medications that we use to treat endometriosis. And when we do so, that does improve our pregnancy outcomes or embryo transfer outcomes. It looks like you have used immune level 4 in the past. So that's pulling out the big guns to try to suppress some of the immune response. But I would think that adenomyosis is probably better served by trying to address it hormonally. Even though it's a mechanical problem, it is something that is fed by the hormones. So if we can adjust the volume knob on those hormones, we may be able to have an effect on how adenomyosis affects your uterus. So hopefully that's a question that is answered for you there. I think we're going to end up having to start to wrap it up here. I sure have enjoyed being with you guys. As always, every Tuesday at 4 p.m. Mountain Time, 6 p.m. on the East Coast, 3 p.m. for our friends on the West Coast, and 5 p.m. in the other place. I can't forget Central Time. Thank you for all those who gave the well wishes to my dad in Alabama, and kisses to all of you and to him. Hopefully he'll have a chance to watch this recording later on. Hey, CNY Fertility is here really for one reason, and that is to bring you a family, to do everything that we can in our power to make your dreams come true. So if there's anything that we can do to help, I sure hope that you will reach out to us. And thank you again for letting us be a part of your lives and for letting me be a part of your evening. So God bless to everyone. Hope to see you here in Colorado. Until next week, I'm Dr. Randy Fink from Colorado Springs, wishing you all the very best. Good night.